Great, thank you. And then I'm going to introduce our last speaker for the first part of this session, and it's Dr. Favian Su, and he's going to be speaking about, does MR arthrography improve evaluation of patients with posterior instability, and analysis from the Moon Shoulder Instability Group.
All right, good morning, everyone. These are disclosures, none of which are relevant to this talk. So posterior shoulder instability is uncommon and it accounts for approximately 10% of all shoulder instability events. However, these injuries can be devastating as only 35% of young athletes return to sport at the pre-injury level and 60% return to sport at some level at long-term follow-up. The diagnosis of posterior shoulder instability is often difficult given that the presentation is vague and that physical exam maneuvers like the Kim and jerk test have limited sensitivity. Advanced imaging, such as MRI, can aid in a diagnostic evaluation of patients with posterior shoulder instability, and multiple prior studies have shown that MRA to be superior to MRI in the diagnosis of labral lesions. However, these studies were all limited by combining patients with anterior shoulder instability, slap tears, with patients with posterior shoulder instability. So, in the literature, it is unclear what the benefit of MR arthrography over conventional MRI is. Furthermore, arthrography is a invasive procedure to the patient and requires additional cost and time. Therefore, the purpose of our study was to compare the accuracy of MR arthrography and conventional MRI in detecting labral, chondral, and osseous lesions in patients with posterior shoulder instability. We hypothesized that the MRA would be superior to MRI. So we work with the Moon Shoulder Instability Group to address this question. Moon Shoulder Instability is a prospective multi-center study that started enrollment in 2012. The study is based out of the University of Iowa and includes 10 other sites, including UCSF and Vanderbilt University. So a total of 310 patients with posterior shoulder instability were enrolled. 13 did not have an MRI or had an incomplete MRI, and an additional 5 patients had an acute traumatic effusion, which were excluded. Thus, our final cohort consisted of 89 patients with conventional MRIs and 230 patients with MR arthrograms. A fellowship-trained musculoskeletal radiologist with over 10-year experience and an orthopedic surgeon evaluated all images. They were all blinded to all clinical information except that patients with posterior shoulder instability was their diagnosis. Images were evaluated for the presence, location, and size of labral, chondral, and osseous lesions, and all MR images were at least 1.5 Tesla field strength. Fisher's or chi-square tests were used to compare the sensitivities and specificities of MRI and MR arthrogram using arthroscopy as the gold standard. So there were no differences between patients who received an MRI and MR arthrogram, except that patients who had an MR arthrogram were a bit younger. On imaging, we found that labral tear was present in 95% of patients. These tears tended to extend from the 7 o'clock to the 11 o'clock position, and the tear size on MR was about 155 degrees. These tears, when compared to arthroscopy, were a bit bigger by about 45 degrees. Looking at the sensitivity, both MRI and MR arthrograms had excellent sensitivities in the 95-96%, although their specificity was much lower. There was no difference between these two imaging techniques. Turning our attention to glenoid bone loss, 34 patients had glenoid bone loss on imaging compared to 4.4% of patients on arthroscopy. The mean bone loss was 11.8%, and the mean vector of bone loss was 823. MR arthrography did have a higher sensitivity than MRI, though this was not statistically significant, and there was no difference in the specificity. Moving on to the humeral side, we see that on imaging, we found 12.8% of patients had a reverse Hill-Sachs lesion compared to 11.4% on arthroscopy. The mean depth was 2.4 and the mean width was 10.7. For identifying reverse Hill-Sachs lesions, both MRI and MRA had excellent sensitivity and specificity with no difference between the imaging techniques. And lastly, looking at chondral lesions, 9.9% of patients had a glenoid cartilage lesion compared to 18.6% identified on arthroscopy. Most of the glenoid cartilage lesions occurred in the posterior and posterior inferior regions of the glenoid. And 13% of patients also had a humeral-sided cartilage lesion on imaging compared to 15.4% on arthroscopy. Both MRI and MR arthrography had very poor sensitivities in identifying glenoid and humeral cartilage lesions, and there was no difference between these imaging techniques. So it's important to consider the results of this study in the context of its limitations. First, it was a single reader. It was a highly skilled, high-volume musculoskeletal radiologist. So these results may not be necessarily extrapolated to a community practice. Furthermore, the MR protocols differed among institutions in terms of field strength, pixel size, slice thickness, and sequence type. And lastly, the duration between imaging and surgery varied between the modalities. So the results of the findings suggest that the addition of an arthrogram does not improve diagnostic evaluation of labral, osseous, or chondral lesions in patients with posterior shoulder instability. And it is also important to highlight that an arthrogram is an invasive, time-consuming, and costly procedure. To put things into perspective, using 2024 Medicare data, the arthrogram increases healthcare costs by 283%. So I think as healthcare costs continue to increase, these findings would suggest that the addition of an arthrogram does not justify its use in patients with posterior shoulder instability, given that it does not add any diagnostic benefit. Thank you.
Great, thanks a lot. And Favian, actually, just while we're tailing on your talk, I just had a question. First of all, were you surprised that there was no significant difference in terms of with and without the arthrogram detecting posterior labrum tears, and just how do you think that extrapolates into other areas of the labrum in terms of recommending arthrogram versus no arthrogram?
So I think that one thing that I noticed is that we often look for like a linear white line in the labrum to determine whether or not it's torn. From a radiologist's perspective, I discussed with them, you have to look at the morphology of the glenoid labrum. So if it's lost its triangular shape, if it looks bulbous, those are all other imaging signs that the labrum is torn. And as we start to read more and more of these MRIs, it becomes quite apparent that you can just kind of tell without an arthrogram.
Okay, thank you. Yes, and Dr. Louie and Dr. Wright, do you have any specific questions for the presenters?
Yes, I do. Yes. So for Dr. Zhao, an interesting paper. Obviously, I commend you for all the hard work combing through sports articles. It's kind of my passion as well. But to your knowledge, obviously, the information you shared with us today would basically be gold for the NFL Players Association to convert all these fields to grass, obviously. To your knowledge, is there a similar study being done and shared information between the team physicians of these NFL teams? And if so, why aren't they sharing that to the public?
So it's incredibly hard to get access to the NFL database. They're pretty private about that. There was an early study of kind of athletic trainers within the NFL who noted something similarly, but I believe that data was between like the early 2000s, 2010. So it was before they all standardized to field turf. And so a lot of that data is pretty variable. And I think that people are kind of hesitant to make that big switch. And I think that a lot of the times like I mentioned, there's like a benefit to having that turf. So a lot of work has also been put towards making that turf itself better, aside from just switching.
So to follow up on that, so first of all, I think all the studies just show the power, great job everybody, and show the power of large database and the ability to really find significant findings. But yes, this has been seen in the league with increased ACL and external rotation syndesmosis injuries. And I argue, so we took care of the Rams until we sent them back to y'all in California a few years ago. And I would try and convince the players to use shorter cleats on field turf, but they're so afraid of losing traction and getting burned or beat. And they wear the same length, a lot of them wear the same length cleats on turf as grass, and the turf doesn't give exactly like you showed. And so something has to give, so it's their ankle or their knee. You had a huge jump and I forget the years, 2021, 21, 22, on the field turf injuries. I mean, it was a big jump in injuries. Do you think that was just an aberration, or did something change?
Yeah, we were actually talking about how many years we wanted to include in the paper, just because with COVID and kind of the way that the NFL changed along with COVID, there might have been some change in kind of game dynamics and ability for players to practice, things like that. So I think going forward, it would be good to kind of go back, potentially to even 2005, to kind of capture more and standardize for that.
Great. Well, I think in interest of time, we can move on to the next session.